নাম ভেবেছি ঠিক আছে তাহলে তার পরে কে থাকবে তার পরে থাকবে হচ্ছে তোর রে ম্যাটার ওকে এন্ড ইন রে ম্যাটার তো তিনটে হর্ন থাকে ঠিক আছে anterior horn lateral horn and posterior horn তাহলে each spinal cord এর central canal তার বাইরে হচ্ছে রে ম্যাটার তিনটে হর্ন একটা হচ্ছে anterior horn একটা হচ্ছে lateral horn and another is the posterior তিনটে হর্ন রে ম্যাটার তার পরে যে তোর লেয়ারটা থাকছে লেয়ারটা হচ্ছে তো white matter central canal ray matters and white matters okay now come to the peripheral nerve কি central nerve here now extend from the central to peripheral part the central part and the contribution in the our whole body is the peripheral now peripheral nervous system কি থাকে তো cranial nerve থাকে কতগুলো cranial nerve থাকে বলেন 11 কি আছে প্রথম শুরু কর ফার্স্ট হচ্ছে অলফ্যাক্টরি নেক্সট হচ্ছে অপটিক থার্ড হচ্ছে অসিলোমোটর ফোর্থ হচ্ছে কক্লিয়ার ফিফথ ট্রাইজেমিনাল সিক্স সেভেন এসিয়া এইট vestibular cochlea তাইতো কি তাইতো কি নাইন কি দেবা কে না কে দেবা নাইন কি হাইপোক্লাস অ্যাকুসেট কে দেবা 11 hypoglossal hypoglossal actual the spinal system body next spinal nerve is 31 pair it is 31 pair not into 100 into 2 okay আর কি থাকে তো প্যারাভার্টিব্রাল সিম্পাথেটিক প্রেসার এটি হলো ভার্টিব্রাল প্রতিটি এই হলো এরিয়া ভার্টিব্রাল এখান দিয়ে মানে তোর যে লাভ হয়ে গেছে এটি এক্স্যাক্টলি এই children at way below it passes across the that is the paravertebral sympathetic plexus okay আর কি থাকে প্রি এন্ড পোস্ট ক্যারিওটিক অটোনোমিক ফাইবার তাহলে স্পাইনাল যে আমাদের পেরিফেরাল নার্ভ কনসিস্ট অফ 4 ফার্স্ট হচ্ছে ক্রেনিয়াল নার্ভস 12 নেক্সট দ্য স্পাইনাল নার্ভ 31 পেয়ারস নাম্বার 3 হচ্ছে প্যারাভার্টিব্রাল সিম্পাথেটিক প্লেক্সাস and fourth হচ্ছে precaryotic and postcaryotic autonomic fibers হলো কি কারণ পরিচয় আমরা করব নেক্সট হচ্ছে তো ক্রেনিয়াল নার্ভ বলে দিলাম নেক্সট হচ্ছে স্পাইনাল নার্ভ কি হচ্ছে স্পাইনাল নার্ভে there is a two nerve one is the motor and one is the sensory. Motor part of spinal nerve arising from the ventral part of the spinal and sensory part it is the ventral means anterior okay and dorsal means posterior okay लेकिन माया वाले का कॉन्फ्यूजन में बोल दे कि कोथा होता है ventral कोथा होता है anterior कोथा होता है dorsal कोथा होता है posterior Now, ventral means anterior and dorsal means posterior. And that is a law called Bell-Pleasant law. It is motor fibers, they are arising from the ventral part, and the sensory part, they are arising from your dorsal part. And it is the rule. So, this rule is called Bell-Pleasant law. Now, in ventral part is two parts. But in ventral part is ventral, anterior, okay. That two parts are that is sympathetic and that is parasympathetic. The sympathetic one is from your T1 to L2 particular, and parasympathetic it is originated from the H1, H2. Correct? Sympathetic, parasympathetic are originally altogether. Motor, sympathetic and parasympathetic. Sympathetic it is originated from T1 to L2. And correct? T1 from thoracic to lumbar. And parasympathetic from the sacrum. Okay? আর কি থাকে? আর থাকে হচ্ছে autonomic pre-embryonic nerve fiber. Autonomic nerve fiber. Okay, এটার মাধ্যমে অর্জন করে শব্দ রেমেটা একটা স্পাইনাল। তারপর তারপরে রেমেটা। ওকে, তাহলে স্পাইনাল ক্যানালের মধ্যে আবার তো তিনটে ডিভিশন, অ্যান্টেরিয়র, পোস্টেরিয়র, ল্যাটারাল। অ্যান্টেরিয়র মানে হচ্ছে তোর ভেন্ট্রাল পার্ট, পোস্টেরিয়র, ডরসাল। স্পাইনাল কর্ড তার দুটো ভাগ, একটা হচ্ছে সেন্সরি, একটা মোটর। মোটর অলওয়েজ ফ্রম ভেন্ট্রাল এন্ড অ্যান্টেরিয়র পার্ট, সেন্সরি ফ্রম ডরসাল অর পোস্টেরিয়র পার্ট। এটা ফিক্স, দ্যাট ইজ কল্ড সেন্সরি। এবারে হচ্ছে মোটরের দুটো পার্ট, একটা হচ্ছে সিম্প্যাথেটিক এন্ড প্যারাসিম্প্যাথেটিক। Sympathetic কোথায়? from thoracic আর lumbar part. What is parasympathetic? It is originating from your sacrum. আর কি থাকে? আর থাকে হচ্ছে তো autonomic pre-ganglionic nerve fiber. Autonomic pre-ganglionic nerve fiber it is originated from your brain matter of the spinal cord. আপনারা বলুন কি হয়েছে? নেক্সট হচ্ছে তো dorsal part তো বলে দিলাম। dorsal part হচ্ছে sensory nerve fiber, all sensory nerve fiber are originating from the dorsal part of the spinal cord. তাহলে ক্লাস 12 এর স্টুডেন্ট কত ধরে ধরে নেয় এটা স্পাইনাল কর্ড, এই একটা নাম থাকে ভিটিকাল কর্ড, একটা নাম এটা হচ্ছে স্পাইনাল কর্ড না, আর এটা তাহলে এখান থেকে কি হবে? এখান থেকে ফ্র্যাকশন কি হবে? নাম ওকে। তাহলে হেড হলো স্পাইনাল কর্ড, হেড হলো তো সিএস, cerebrospinal fluids. Cerebrospinal fluids it is there is a connection between the brain and spinal cord. তাহলে কানেকশনটা কি হচ্ছে? তো ল্যাটারাল ভেন্ট্রিকলস, ল্যাটারাল ভেন্ট্রিকলস থেকে হচ্ছে তো হার্ট ভেন্ট্রিকলস, হার্ট ভেন্ট্রিকলস থেকে হচ্ছে ফোর্থ ভেন্ট্রিকলস, ফোর্থ ভেন্ট্রিকলস থেকে দুটো পার্ট হয়ে যায়। একটা পার্ট হচ্ছে অ্যারাকনয়েড মেটার্স, in arachnoid space, আরেকটা হচ্ছে ডাইরেক্ট সিগনেচার। এই সিএসএফ কথা কোথায় চলে যাচ্ছে? এটা ল্যাটারাল ভেন্ট্রিকল, সেই ল্যাটারাল ভেন্ট্রিকল থেকে কোথায় আসছে? এটা হার্ট ভেন্ট্রিকল, হার্ট ভেন্ট্রিকল থেকে কোথায় আসছে? হিট ফোর্থ, ফোর্থ থেকে কি হচ্ছে? তো foramen of mesentery and foramen of plaster, এই দুটো থেকে arachnoid system হচ্ছে একটা পার্ট, আরেকটা পার্ট হচ্ছে ডাইরেক্ট সিগনেচার। way a spinal CSF is produced and they are regulated. কোথায় এই CSF তৈরি হলো? CSF তো কন্টিনিউয়াস তৈরি হয়ে যাচ্ছে। Where it absorb হচ্ছে তো পুরো যে ভেনাস প্লেক্সাস থাকে পুরো ডেলি আমার ফ্রি পাবে, তাই না? তো পুরো মেটার বায়োমেটার এন্ড ই একবার তাহলে পুরো যে সেল পুরো মেটার যে ভেনাস প্লেক্সাস থাকে, these venous plexus are responsible for the absorption of CSF. Okay, তাহলে CSF ওখানে তো absorb তৈরি হলো ন্যাটারোমিটার থেকে absorb হলো এটা dural venous plexus of the dural meter. Okay, next হচ্ছে তো why the CSF is so important, because in that any type of brain tumor, they be brain tumor or brain malignancy, they be যখন ধরা পড়ে তখন মানে জেনারেল রুল হচ্ছে when some tumor is metastasis in your brain, the minimum survival rate is in and around 6 months. যদি বিলেটর কোনো ক্যান্সার মেটাস্টেসিস করে বড় মধ্যে 6 মাসের মধ্যে মোটামুটি যা হবে আপনি তাহলে আমাদের যখন ব্রেনে যখন আলটিমেটলি জমা হয় তখন কিছু ভুলে তাহলে সিস্টেমের কাজটা কি হচ্ছে, যদি কিছু হতো তাহলে আমাদের একটা কথা বলতে হতো ভিজুয়াল ডিস্টারবেন্স হতো, তাই না? আমরা এই রাইট ফর্ম tumor of the brain, they create the visual disturbance, headache, dizziness, forgetfulness, all this stuff. But when it metastasis, the pressure is because brain is a disease box. Otherwise, scala the company distribute to abdomen. তাহলে তোর কি করছে সিরিয়াসলি কি করছে ওই ডিজিট বক্সের মধ্যে একটা স্পেস ক্রিয়েট করে দিচ্ছে যাতে any type of raised intracranial pressure that not be to manifest of early. Okay. Now second one is to any type of ADG যখন হয় তখন কি করে CSF একটাকে বাফার মধ্যে থাকে because it to fit in একটাকে বাফার and to minimize the trauma of the heart and the structure of the brain. So this is the CSF component. Now, normal structure of the CSF কি হয়? তো এখন CSF কারণে দেখি normal CSF এর মধ্যে normal সেল কত থাকে? সেল থাকে generally 0 to 5 and definitely all cell are in protein তো সুগার মধ্যে সুগার যদি থাকে হচ্ছে अराउंड 50 to 80 CSF থেকে তোদের কিন্তু প্রোগ্রাম আপনার এপিএস যখন লিপিড সিস্টেম থেকে একটা রুল ঠিক আছে তো সেল বললাম 0.5 what are the ingredients? This is the sugar is the 50 to 80. What is normal glucose? It is the 2/3 of the blood sugar. Okay, 2/3 of the blood sugar. মানে 80 হলে normal blood sugar হলো 120. 2/3 of the blood sugar is the same. If it is high, then you have to diagnose other. Next chloride. Chloride is 720 to 750. Okay, protein 20 to 50. Why is and also the reach of sodium, potassium, calcium, magnesium, all the minerals are reaching CSF. Why is value are important. You know that there is three types of meningitis. One is the bacterial meningitis, next the viral meningitis, and third the fungal meningitis. So you have to differentiate the three meningitis according and also the color spaces. CSF is like so normal field color. If you make the color, CSF color is the same. Normal. So by this you can differentiate the three types of meningitis. So it starts with the viral meningitis. Viral meningitis is appearance. So that is another viral meningitis. We have CSF currently, CSF is like normal, what is the color, that is the same color, no color change. But when you tap in, CSF are like split, but that is opening pressure is so much high. And why this? You try first time to find that it is the probably now practice করতে নাও জানি যখন তোমরা সিএসএ করতে যদি কোনো ল্যাবরেটরিতে তারা দেখি সব সময় যেটা ওপেনিং প্রেসারটি হাই and this is the indications of a viral meningitis. Opening pressure high and CSF it is the normal cell. Third cell in viral meningitis cell count increases and obviously all are increases. Okay. In cases of proteins, in viral meningitis, proteins are increased, but sugar level and chloride level are not. What about TB? TB meningitis is the most common. Meningitis is the CSF TB in the test tube that is a precipitate. And this precipitate is called co-wave coagulum, and it is the marker of your TB meningitis. Co-wave coagulums. Bacterial and obviously in TB meningitis, lymphocyte count is high, and there is a marker comes with the ADA, and ADA is also high. What about bacterial meningitis? Bacterial meningitis in the CSF, the count increase and all the cells are neutrophils. Neutrophils are eliminated. Body of TLS are high. Okay. So by this you can differentiate different types of diseases of the CSF. Okay. And site of acidification of CSF is always in between L2 and L3 article. Okay. So this is in brief the structure of your brain. এবার তোমরা অ্যানাটমি যে এই বাকি স্ট্রাকচারগুলো করতে নিউট্রিশন এর সম্পর্ক নেই কিন্তু সিএসএফ পরীক্ষার সম্পর্ক আছে. Okay. Next topic, যেটা পড়া হবে সেটা তোমরা আবার থেকে ভালো জানিস, that is the neuron. তাই তো নিউরনটা আপনি ভালো জানেন. Is in neuron. So neurons, you know, cell body and second is the axon. Okay. Now cell body is from soma. Hello. So cell body কি থাকে আমাদের মাঝখানে যে বোন স্ট্রাকচারটা দ্যাট ইজ কল্ড দা সেন্ট্রিওল. ওকে, ইট ইজ ভেরি ইম্পর্টেন্ট. নেক্সট থাকে কি এখানে ডট ডট থাকে দ্যাট ইজ কল্ড রিজল ক্যানিউল. And it is our ribonucleoproteins and it is just like a normal rough intraepithelial reticulum in the normal cell. Normal cell is a rough reticulum, that is visual glands. Okay, article neurofibril থাকে. Neurofibril is a fibril-like structure. They are enormous in structure. They are just located in the cell that is called soma. Arti থাকে আপনারা হচ্ছে dendrites. Dendrites is a projection from the your cell. Cell থেকে projection থাকে তাকে বলা হচ্ছে soma. And in the dendrites there is a knob. That is called dendritic knob. What is the function of dendrites? Function কি আছে? They receive the electronic impulse from the your next order neuron. Next order neuron থেকে electronic impulse they can carry forward. That is the function of dendritic knob. Okay. এই সেন্টারে কি বলে in between the cell and the myelin এই সেন্টারে কি বলে বল এটা তো ক্লাস করতে হবে অ্যাকশন দি তাই না what is the function of the what it is the structure where a action potential is generated. এখানে action potential generated. Okay. Next হচ্ছে তো that is the myelin sheath. এগুলো myelin sheath তাই তো ওইটা খারাপ কিন্তু it is the myelin sheath here. In between myelin sheath के gap হলে কি বলে nodes of ganglion. Nodes of ganglion. তাহলে that is the universal that is the uniform structure and the uniform gap. In roughly 1 millimeter apart. এগুলো 1 millimeter apart থাকে. What is the last part? Last part is क्या है ना? What is this? Ina. Axon terminal. And axon terminal is the that is a knob. Knob नाम क्या है? Terminal knob. Function क्या है? It separates the acetylcholine. And acetylcholine is the responsible for the synaptic junctions. ঠিক আছে? এই তো নার্ভাল পার্ট কি আছে? Great. Now there is a few properties of nerve. যেটা আমি স্যারকে এগুলো পড়িয়েছি এগুলো সব তো জানি। এরপর তোকে ভ্যান্টিভিয়ার প্র্যাকটিক্যাল হবে। তো ভ্যান্টিভিয়ার প্র্যাকটিক্যাল যদি এগুলো না জানিস তাহলে কিন্তু এই যে মানে যেগুলো লাগে সেটা জানতে হবে মানে স্যার what is the excitability of a nerve? Excitability means যে threshold of stimulus that produce an action potential in a nerve. That is called the excitability. Okay. And the excitability of a nerve we can measure by phonexy দিয়ে আমাদের excitability of the nerve measure করা হয়. Okay. Next is the resting membrane potential. What is the resting membrane potential? মানে একটা নার্ভ আছে যাকে তুমি বিরক্ত করছো। এই যেমন পিছনে কিছু লোক বকবক করছে। হ্যাঁ, তো বিরক্ত না করে নরমাল অবস্থা থাকে, তাহলে তার যে অ্যাকশন পোটেনশিয়াল তাকে বলা হচ্ছে রেস্টিং মেমব্রেন পোটেনশিয়াল। হোয়াট ইজ দ্য ভ্যালু? -70 মিলি। দ্যাট ইজ কল্ড রেস্টিং মেমব্রেন পোটেনশিয়াল। নেক্সট হচ্ছে লেটেন্ট পিরিয়ড। হোয়াট ইজ দ্য লেটেন্ট পিরিয়ড? তুই পিছনে গল্প করি যাচ্ছিস, হ্যাঁ আমি দেখি যাচ্ছি, গিয়ে একটা সময় পর কি হলো, আমি ভুলে গেলাম। তাহলে কি আমাদের স্টিমুলাস কিন্তু আমার সেই রেকর্ডটা পৌঁছতে সময় লাগবে, যখন আমি করি। And in between this period is called latent. তাহলে when we give a stimulus and there is a production of a action potential. The time difference between the given potential and the action potential, that is called the latent period. So it is a latent period. So we are going to do. Next is local response. Local response মানে হচ্ছে তুই একটা নার্ভকে অল্প অল্প করে স্টিমুলাস দিয়ে যাচ্ছিস। যখনই তুই স্টিমুলাস দিবি কি হবে? জেনারেট অ্যাকশন পোটেনশিয়াল। বাট as the stimulus দিচ্ছিস এটা খুব অল্প, that is not a threshold level. তাহলে they generate the response but not up to a action potential. And this excitability are migrated only locally, and this is called a local response. মানে তোর আমরা তুই পরীক্ষার সময় জানিস না, হ্যাঁ তুই সামনে যে ছেলেটা আছে তাকে যেটা বলবে, হ্যাঁ একবার বলবি, দুবার বলবি, তিনবার বলবি, চারবার বলবি, দিয়ে তারপর থেকে কোনো রেসপন্স আসছে না, তুই বলাইছ। হ্যাঁ, তাহলে কি হচ্ছে? তাহলে হচ্ছে you cannot produce the desirable level, তাই না? এটা উত্তরটা বলতে পারে, তাই না? তো that is called the local response. স্টিমুলাস হচ্ছে, কিন্তু তাদের যে রেসপন্সটা হচ্ছে, যে রেসপন্স are only transmitted locally. They not produce action potential. So that is called the local response. Now the action potentials, you give a nerve a stimulus and this produce the threshold level of the neuron and this produce the action potential. Okay. এবার হচ্ছে all or none now. What is all or none now? After giving a stimulus of a nerve as we generate the action potential, you cannot amplify the stimulus by giving a late stimulus. মানে একটা নার্ভকে তুমি স্টিমুলেট করেছিস, এটা অ্যাকশন পোটেনশিয়ালে আছে, তারপর তুমি আর স্টিমুলাস নতুন করে দিয়ে একটা নতুন করে দিয়ে অ্যাকশন পোটেনশিয়াল জেনারেট করতে পারবে। That is called all or none law. Now next হচ্ছে তো refractory period. What is refractory period? Refractory period is two types. একটা হচ্ছে তো absolute, একটা হচ্ছে relative. Absolute মানে হচ্ছে যখন তুমি সাইডের স্টেটে আছে ইউ অ্যাকশন পোটেনশিয়ালে আছে কি তাকে নতুন করে স্টিমুলাস দিয়ে পুরো অ্যাকশন পোটেনশিয়াল বের করতে পারবে দ্যাট ইজ কল্ড দ্য অ্যাবসলিউট রিফ্লেক্টরি ফোর্স হোয়াট ইজ রিলেটেড রিফ্লেক্টরি ফোর্স একটা কি নার্ভে স্টিমুলাস দিলে নট ওকে 100 মিলিমিটার স্টিমুলাস নার্ভ অ্যাকশন বের করবে নেক্সট হচ্ছে যখন কি স্টিমুলাস দিলে অ্যাকশন জায়গায় হবে 150 so that is a stronger stimuli from the previous and that cases you might generate the action potential in that is called the electric the case when actually child your strongly is no action potential because after that action potential so your generate করছে relative হচ্ছে going to the solar will be stronger like this how your previous one it might get generate action potential than the previous one very good it must be the stronger now the third conductivity মানে হচ্ছে একটা নার্ভ কন্ডাক্ট করছে নার্ভ ইম্পালস you know the nerve are different myelinated and unmyelinated ঠিক আছে so there is a law হচ্ছে তো যে there is a protein and there is a neurotransmitter এখানে কি ক্যারি করবে protein আর neurotransmitter protein এর ক্ষেত্রে কি হচ্ছে তো as neurotransmitter are lighter because they are secreted at the speed of light. So, when in case of neurotransmitter, the conduction is high because their molecular weight is low. But when their molecular weight is high, in case of protein, their conduction is low. And again, myelinated and unmyelinated, myelinated structure to pure conductivity much higher than the unmyelinated. Whatever, cannot myelinated that primary conduction high, cannot because so I told you action potential are generated होते हैं जिसका action है that is the myelinated structure and myelinated are done and the myelinated tube they are made up of lipids and lipids are insoluble এখানে কি হচ্ছে তো যখন তোর অ্যাকশন পোটেনশিয়াল জেনারেট হচ্ছে এই অ্যাকশন পোটেনশিয়াল এখান থেকে নেক্সট অ্যাকশন পোটেনশিয়াল কোথায় জেনারেট হবে এখানে স্টার্ট করা হবে এখানে in between the roots of radius and action কিভাবে আসবে এখান that is called the solitary conduction okay এটা হচ্ছে তো ইকুয়েশন মাইনাস ট্রান্সফার এবারে তো আনমাইনাস কি হবে এটা আনমাইনাস এখানে কি হবে and each nullify the next মানে কি হবে এতগুলো কন্ডাকশন যেভাবে হবে they are not possible to propagate as faster than the myelinated so in myelinated বলে কি হচ্ছে না তো একটা হচ্ছে কন্ডাকশন তো ক্যাটাগরি হচ্ছে দুটো যেহেতু একটা ইনসুলেটর টাইপ মাইলিন থাকে এই যে একটা কথা মানে কি দা সোডিয়াম পটাশিয়ামের তো একটা সিলেবল ক্যাটাগরি মানে কি হচ্ছে সোডিয়াম পটাশিয়াম এটিপিএস পাও পটাশিয়াম বাইরে বেরিয়ে যাচ্ছে সোডিয়াম ভিতরে তাহলে এইখানে যে কি আছে সোডিয়াম পটাশিয়াম কি আছে এই সোডিয়াম পটাশিয়ামটা কি হবে যেহেতু তো মাইলিন থেকে আছে সেহেতু দেয়ার একটা বিলিং আউটসাইড পুরা পুরা বুঝতে পারবে এখানে কি হচ্ছে এখানে তো কিছু অ্যাকশন করতে আছে আর ঠিক আছে হয়ে যাচ্ছে তাহলে কি হচ্ছে লিভিং অ্যাকশন so they are not as much productive as the so highlighted one. So that is a full procedure in case of highlighted null. That is the diameter 6 to 6. মানে কি হচ্ছে ধর একটা ধর 12 সেমি মাইক্রোমিটার নার্ভাস ফাইবার তাহলে কি হচ্ছে কনভার্সন টা 6 into 12 is 72. In case of unrelated, it is the root square of the null. 16 যদি হয় তাহলে ওর ইয়ে কত হবে 4 in unrelated. So that is it. Next is the axonal transfer. Okay, axonal transfer মানে হচ্ছে তো that is a two type of protein other থাকে in the axon. That is the kinesin and dynesin. Kinesin যেটা হচ্ছে সেটা হচ্ছে তো entrogate and dynesin হচ্ছে in the retrograde. Retrograde কোথায় আছে? Retrograde of the retrograde তো রাখা হচ্ছে in the sinus. Sinus যদি আমাদের হয় তাহলে sinus কি হবে? sinus মানে হচ্ছে তোর পাইপো লাগানো ইনজুরি। sinus কোথায় আছে? in the soil. এই যে বলে ওয়াটার থেকে কি হয় কেন বিকজ ইন্টারনাস যে অক্সিজেন ফিলিং দ্যাট ইজ প্রেজেন্ট ইন দ্য সয়েল so from that the intravenous toxin enter into the blood and they are enter কোথায় যায় ব্রেনে because they produce the hyperexcitability কি করে যাবে by the retrograde इस तरीके से होना जाता है और एंट्रोपिक क्या होता है एंट्रोपिक मतलब तो ये हमारे नॉर्मल के तो नॉट इम्पल्स नॉर्मल ये इंजन मूवमेंट एक्सटेंसिव मूवमेंट ऑल का कोर्स का एंट्रोपिक मतलब एंट्रोपिक फ्रॉम द सेल बॉडी टू द नो टर्मिनल that is called the endocrine. Endocrine is a particle now to endocrine. Okay. Now, third part is for neuralgia. Neuralgia means that is for neuralgia first part is for astrocyte. Astrocyte is there is two types of astrocyte. Now, so fibrous astrocyte and the protoplasmic astrocyte. ठीक है now fibrous astrocyte और protoplasmic astrocyte যেটা আছে সেটা হচ্ছে তো fibrous কে মেয়ার what is fibrous because they are filamentous substance so that is called fibrous and protoplasmic because they are rich of cytoplasm and this cytoplasm contains granule. So this really protoplasmic astrocytes. और एटल यूज करके तो एक्सरसाइज करो तो ले लो बिकॉज़ एक्सरसाइज की होते हैं एक्सरसाइज के स्ट्रक्चर स्केलेट स्ट्रक्चर কি করে এটার নাম আমাদের একটা ব্লাড ও এখান থেকে প্রজেকশন যে দিবাস এই ব্লাড সেলটাকে এরকম blood cell के walk को एक्सरसाइज की नाम by what is the blood vessel it produce the blood-brain barrier. Okay, blood-brain barrier it forms the blood-brain barrier. আর কি করে exercise আমাদের ধর হবে না তো একটা স্ট্রোক মানে স্ট্রোক মানে সিম্পল স্ট্রোক মানে নাক কাটা যাবে ও কি করে যে যে absorb the potassium in the radio shape. ইসের থেকে ওর পটাশিয়ামকে সরিয়ে নেয়। তাহলে শরীরের কি হবে? যে চেঞ্জ ইনসাইড করা হবে। এই করাটা কি চেঞ্জ হবে? ধর একটা নার্ভ কন্টিনিউয়াস স্টিমুলাস। এই স্টিমুলাস এর দ্বারা কোনো ডিক্লোরেশন হবে। তাই তো ডিক্লোরেশন এন্ড লাস্টলি কি হবে? ডিক্লোরেশন। অল্পটা কি সোডিয়াম পটাশিয়াম ইনসাইড দ্য সেল পটাশিয়াম বেশি আউটসাইড দ্য সেল সোডিয়াম বেশি। আমি যখন ডিক্লোরেশন হচ্ছে তখন কি হবে? সেল থেকে potassium বাইরে চলে যাবে and the PCS সামান্য একটু স্টিমুলাস দিলে ওই নামটা বুঝতে পারবে। এবারে আমরা শুরু করি সেই নামটা যদি কন্টিনিউয়াস স্টিমুলাস দিলে হাইপোস্টিমুলেট তাহলে কি হবে? এই নামটা ফার্দার ক্যারেক্টার একটা নাম অলরেডি স্ট্রোক হয়ে স্ট্রোকের ভিতরে ব্লাড সাপ্লাই নামটা চাই আর ফিউডেন্স সেই নামটাকে যদি যেহেতু পটাশিয়াম মাইন্ড বেশি থাকে সে আগে থেকে আমি নিচে তাহলে কি হচ্ছে ওই নামকে অল্প একটু এটি স্টুডেন্টের হয়ে যাবে আর বিরাট স্টুডেন্টের কন্টিনিউয়াস একসময় কি করে এই পটাশিয়ামটা কন্টিনিউয়াস হয়ে যায় তারপরে কি হয় রেস্টিং মোমেন্ট পটেনশিয়াল বিশা হায়ার so any suboptimal stimulus not produce any action potential so those damages বলতো নেক্সট কি করে ও কি করে গ্লুটামেট থেকে গ্লুটামিন তৈরি করে গ্লুটামিন তৈরি করে কি লাভ হচ্ছে because by the process of glutamate to produce glutamine they remove the ammonia from the blood and this ammonia is highly toxic to the brain example কি আছে তোমরা এখন ওয়ার্ডে যাবি তোর কিডনি পেশেন্ট গুলো দেখবি একটু উঁচু হলে ঘুরপাক করছে কেন বিকজ দ্যাট ইজ ইউরিন ইনটলারেন্স অ্যামোনিয়া জমা এবারে কি হয় এটা যদি ডিফার অ্যাক্সিডাল দেওয়া হয় ডিফাক্টিভ ট্যাবলেট দেওয়া হয় বিকজ টু রিমুভ দ্যাট অ্যামোনিয়া ইন দ্য ব্লাড ঠিক আছে নেক্সট হচ্ছে গ্লুকোজ গ্লুকোজ কি হয় গ্লুকোজ হচ্ছে তো it absorbs the glucose from the ECM and it produces the lactate and this lactate is essential for the ATP production of the nerve. Okay. So this is the function of astrocytes. Hello. Next is the oligodendrocyte. Oligodendrocyte is the two part that is the swan cell and the oligodendrocyte. Oligodendrocyte and swan cell পার্থক্য কি আছে? Swan cell it produce myelination in the periphery of the periphery of and cellular nervous system নিয়ে পড়ে oligodendrocyte. Swan cell and oligodendrocyte এর পার্থক্য হচ্ছে swan cell তৈরি করে periphery and oligodendrocyte তৈরি করতে এটা cellular part of the next হচ্ছে তো ependymal cell কি হয় the cell related to our hollow tube করে হয় in the ventricles and the spinal cord করে it produce the CSF একটা হচ্ছে they have ciliated structure and ciliated structure it get into pass the CSF from the lateral ventricle to the up to the right. The venous plexus that get the circulate reflect করছে তিন নম্বর হচ্ছে it have a neural crystal থাকে so that they have a property to generate the neurons. Okay, so that is the function of ependymal. Next হচ্ছে তো myelination কি হচ্ছে myelination যেটা হচ্ছে nerve central is what central oligonucleotide and peripheral oligonucleotide small. So small cell কি করে because একটা হচ্ছে মাইগ্রেটেড একটা হচ্ছে নন মাইগ্রেটেড কি হয় তো এটা হলো নার্ভ ফাইবার আর এটা হলো small cell কি করতে unmigrated থেকে বেরিয়ে only once একবার রাউন্ডলি বেরিয়ে in unmigrated nerve fiber in case of migrated nerve fiber they are round and round the mind. Okay. The unmigrated that is only one. And this is the migrated that is the 3, 4, 5 round. That is the function of small cell. Next the classification. Classification होते हैं ऐसे classification in this chart. Okay. Our letter and pressure area पर पानी से that is three type of A, B, C, you know, and A, B, C that is the vocals and vocals we again divided into the mixed nerve in the alpha, beta, gamma, delta, and the sensory nerve that is 1, 2, 3, 4, and this is the nodes. I not remember. Okay. So now fiber হচ্ছে তিনটি A, B, C. A, B, C মধ্যে হচ্ছে mixed variety is the 3 part, 4 part, alpha, beta, gamma, delta. Next the sensory part হচ্ছে 1, 2, 3 and 4. तो उपरটা হচ্ছে তো এটা মানে হচ্ছে সেন্সরি রিলাস কন্ট্রোল ABC को ভাগ হচ্ছে আলফা বিটা গামা ডেল্টা এই যে প্রথম আর দ্বিতীয় পার্টটা যেটা সেন্সরি পার্ট ইজ ডিভাইডেড ইনটু 1 2 3 and 4 ওকে নাও নেক্সট হচ্ছে তো নার্ভ ইনজুরি মানে হচ্ছে একটা নার্ভ তো ক্র্যাশ করে যাওয়া দ্যাট ইজ এ five type of nerve injury. First degree nerve injury, first it is the example of the একটা nerve এর উপর কি আইফোন প্রেসার দিয়ে রাখে and ultimately the pressure that produce the hypoxia of the nerve, oxygen কমে যাচ্ছে and that cause the nerve injury and obviously it is reversible. Example হচ্ছে তো Saturday night pulse কি হয় আমাদের ইউরোপিয়ান কান্ট্রি আমেরিকাতে পার্টি করে একটা চেয়ারের উপর pressure of the radial nerve and that is the pulse of the radial nerve will be reversible. That is called the Saturday night pulse. Second হচ্ছে তো second degree nerve injury হচ্ছে that is injury in the nerve but the endoneural tube একটা টিউব থাকে that is the endoneural tube that is intact. So in future cases of the endoneural tube it is regenerate and the nerve is going back to normal function. Example কি হচ্ছে অনেক সময় আগে কি হতো টিভি ক্ষেত্রে তো স্প্রেডিং নামটা যেটা থাকতো তাকে ক্র্যাশ করে দেওয়া ক্র্যাশ করে দেওয়া because to raise the lungs that is called the second degree okay আর হচ্ছে endoneural tube যেটা আছে সেটাকে there is the destruction of endoneural tube. Fourth degree nerve যে fascicle সেই fascicle গুলো injured হয়েছে and fifth degree there is a complete transduction of the nerve. Okay. Now how nerve is positions এটা ধর না একটা আর উপরে ধর সেল এখানটা ধর কাট হয়ে গেল ঠিক আছে তাহলে কি হবে কোন দেখি যে কম সেলে কি হবে চেঞ্জেস কর্নিকলি চলে যাবে নিউরোফিল চলে যাবে সেলের যে সেন্ট্রিওল এটা ডিস্টার্ব হয়ে যাবে সেলটাকে কে চালায় নিউক্লিয়াস চালায় সেন্ট্রিওল কি চলে যাবে সেটা কি থাকবে থাকবে না নিউরোফিল এটা সেল এটা জয়েন্ট হয়ে যাবে and they are become swelling and round আর এখানে যে মাইলগুলো থাকবে মাইলগুলো কি বলতে না they are made up of lipid তাহলে এটা কি তৈরি করবে লিপিড ডবলেট তৈরি হয়ে যাবে এটা ডিসকাশন হচ্ছে লিপিড ডবলেট তৈরি হয়ে যাবে সেখানে কি হচ্ছে swan cell because swan cell in the capability to macrophage capability so কি করবে ও এটাকে আস্তে আস্তে ইনভার্ট করবে হলো এবারে তো কি হচ্ছে যখন swan cell কি করবে এগুলোকে তো আস্তে আস্তে এটা হচ্ছে হলো মানে যে জায়গাটা সেই জায়গাটা swan cell আস্তে আস্তে তো মানে ডবল করে দিচ্ছে এবারে কি হচ্ছে swan cell থেকে তো একটা পজিশন দিচ্ছে একটা না অনেকগুলো পজিশন দিচ্ছে দ্যাট ইজ কল ইম্পিল এই পজিশনগুলো কিছু চলে যাবে এক কিছু পজিশন কি আসবে এইবার পুরো নিউক্লিয়ার এটা ডিস্টার্ব নিউক্লিয়ার মানে and ultimately with the distal nuclear with the guidance of swan cell they are regenerated এটা বলে organ regeneration তো এটা শর্ট নোট আছে so কি হবে তখন সে now the you are regenerated along with the neurofilaments and they produce the nerve থ্যালাসিক কি হচ্ছে থ্যালাসিক হচ্ছে কারণ হাত পা থেকে বাদ যায় না তো বলে গেল কি আছে অনেক সময় কি হয় নো কানেকশন হচ্ছে কারণ পেন যে ফাইবার সেটা বাদ চলে যাবে এবারে পেন ফাইবারটা আবার তো রিজেনারেট করে কিন্তু কি হলো কিন্তু না পেনটা এবারে সত্যি আছে এবার তো এটা পেন এটা ঠিক করে ঠিক আছে তো সরি এটা পেন এটা কাজ এটা পেন এটা কাজ এখানে কি হচ্ছে তো এটা কি না তাহলে কি হবে কিন্তু যখন আরো অ্যাসিড ইনক্লুড হয়েছে তারপর তার মানে অপারেশন করা হয়েছে সেখানে প্রসেসরটা সিলেক্ট করে কস জেনারেশনটা okay so this is the basic properties of nerve and
diseases in like cancers or carcinomas. And that particular carcinoma more predominantly spreads through the lymph nodes and lymphatics. That's why we have to understand the lymphatic channels where it drains, because in surgery of this particular organ, if it is affected with the cancers, we have to remove that. If you are removing the organs, we have to remove the lymph node as well, because if you do not remove this particular lymph node, because you are leaving the disease behind. No matter how you remove this organ itself, it's not making any sense if you are not removing that particular new host point of these pathogens, which is the lymph nodes where these particular cancer cells are residing. Then we are going to talk briefly about this nerve supply, which involves this particular sympathetic, parasympathetic, just like any organ, not much of a big deal about it. And then we lean to this particular clinical anatomy, which is kind of little bit extensive. So having said that, we start with this particular organ, and this particular organ will be talking to this particular stomach itself today. So this is an organ for digestion, and this particular organ acts as a reservoir as well. So food material, whatever we take, what much of amount we can take it, because this particular organ is distendable and capable of holding it for a time. And once it is holding, it also breaks down this particular food material meanwhile by mixing with some kind of juices which is liberated by this particular organ itself, and breaks down this particular complex food material into simpler form of like carbohydrates, etc., etc. Now this particular organ is located in particular positions in the abdomen or abdominal cavity. It is located in some quadrants of the abdomen. Perhaps by this time we have an understanding of this particular quadrants of this particular abdomen. This is how we divide this abdomen based on this particular, this imaginary lines. We call them as mid-clavicular line, transpyrotic line, transcrystal line, and we split this. Now you can imagine this particular organ placed in this particular schematic picture as we are seeing here is located partly in the rib-coic, partly it is getting out, partly occupying this particular quadrant, we call them as left hypochondrium. It is reaching to the midline quadrant, we call this as epigastric region, and this bottom side, which is known as the umbilical region, upper part of the umbilical region, is also occupied by this particular organ where it is located principally. That means if you have organ which is diseased involving pain or any other problem involving this particular stomach, we can focus to this particular quadrant. If you are going to do surgery, you have to make an incision or cut this particular region through this particular region. You cannot cut here in this particular left iliac region and look for stomach there. So for that reason, you have to understand where exactly the stomach is located. So once you understand this particular location of the stomach, this particular stomach is pretty easy organ to narrate. So it has, we go by the rule of two whenever you are going to describe this particular organ. So we include this particular organ by saying it is organ of rule by two. It has two opening or two ends this particular organ has. We call them as cardiac end, other is known as the pyloric end. Cardiac end is lying in the higher plane and the pyloric end is lying at the bottom end. And it has this particular opening which is lying in this region, which is known as cardiac opening and the pyloric opening. Now going by this particular opening, these particular openings are guarded by physiological or anatomical valves. Now we have to understand what do you know by physiological things and what do you know by the anatomical things. The physiological things, we say that this is non-visible. This is there, but I cannot demonstrate that. So whatever the things is happening or these particular changes in the cells or any blood system is going on, we can understand this is happening, but we cannot demonstrate it. Which is in contra, in anatomy, we can just like show it and tell you about this is what is there and this is making this. So this particular opening is guarded by some kind of like a valve-like structure. We call these valves which is present in the cardiac end, we call them as cardiac sphincter. And this end in the pyrolus, we call them as pyrolic sphincter. Now what is the difference between that? We call this sphincter is physiological. That means whenever you are holding it, cutting it, seeing it, we cannot see any sphincter there. We cannot see any specialization at that particular point which is visible through naked eye. That's why we call them as physiological. Now compared to this end, pyrolic sphincter is visible, palpable, and it works as demonstrable. So this particular sphincter which is present in the pyrolic region, we call them as physiological sphincter. Now this particular opening, we call them as cardiac opening is a physiological opening, and this is anatomical, this is anatomical sphincter which is visible, demonstrable, which is present in this particular pyloric region. Now this particular organ, again by the rule of two, have got two surfaces if you are just like considering it. This is one surface you are looking at, we call them as anterior surface. The back side will be posterior surface. Now if this particular organ is in a flat stage, that means whenever we are hungry, this particular stomach is not distended. That particular undistended state, this particular organ is collapsed and that particular surface becomes anterior and posterior. Now when we take the food material, it gets filled up. It gets like a combustion or churning goes on. It creates some gas. And this particular organ swells up just like what you are seeing here. That particular surface, the anterior one becomes superior and the posterior one becomes inferior. So it moves up and pushes down. So as a result of this, we get two surfaces in two positions of this particular stomach, if it is flat or if it is distended. So clubbing together, we get two surfaces of the stomach. We call them as antero-superior surface and posterior-inferior surface. Comparing or clubbing it together based on two different states, whether the stomach is distended or the stomach is empty. So two surfaces is there. This particular organ looks like J-shaped organ and it has two curves. One is great curve, you can see this visible curve. We call them as greater curvature, and this one is lesser curvature. So there are two curvature which is involving this. We call them as greater curvature and lesser curvature. Now having said these two particular curvature, this particular lesser curvature is fitted with a layer of peritoneum. We call them as omentum. So this particular lesser curvature is attached to that particular margin of it, having a peritoneum fold. We call them as lesser omentum. And this particular curvature which is fitted on peritoneum fold to it, we call them as greater omentum. So we have two peritoneal folds attached to these particular margins. We call them as greater and lesser omentum, respectively attaching on lesser and greater curvatures. So this particular organ have got these two kind of descriptive part related to this particular organ or this particular physiological and anatomical aspects of this particular demonstrated part is concerned. Apart from that, it has two notches. One is on the upper end, we call them as cardiac notch. This is a bend which you're seeing here, and the bottom side also we have a bend over here. So we call this as a cardiac notch and a pyrotic notch. Now the significance of this notch, based on these notches we can draw some imaginary line, and that helps us to divide this particular stomach into three or two different domains. Say for example, this cardiac notch, we draw a horizontal line from this cardiac notch, we get this particular sections of this particular stomach cut over here. So this horizontal line, taking a draw from this particular cardiac notch, the portion which is above this horizontal line, we call them as fundus of stomach. So it is easy to figure out which part is the stomach. This particular notch is pretty much visible. So this cardiac notch, we draw a horizontal line, get the portions of the stomach, we give this particular upper end of the stomach with a name, we call them as fundus of the stomach, and bottom over here, below to, we call them as body. Now the body extends to this particular pyrolic region. Till what point we have this particular notch, we call them as pyrolic notch. This particular pyrolic notch, we'll call them as angular incisor or incisura angularis. In a living condition, when you are doing live surgery, we see a vein running in this particular point. We see a vein, we call them as vein of Mayo or pre-pyloric vein of Mayo, M-A-Y-O. That particular vein, during surgery, we find it and figure out which part is stomach and which part is pylorus, because we have to do surgery in the pyloric region. We'll come into it. So this particular angular notch, which is present in the pyloric region, if you draw again a curved manner, oblique line through here, we get this particular angles over here and find this particular lower limit of the body, and everything beyond that we call them as pyrolus. So this particular stomach can be divided into three parts: fundus, body, and the pyrolus. And this particular pyrolus has a cavity, initial part, and then it has a canal. So we call them as antrum, which is the beginning part of the pyrolus, which is continuous with the body, and then we have this tunnel setting on, which is going down as canal. At this particular pyrolus and this particular part which is continued down with the duodenum, we have a sphincter existing in here. We call this sphincter as pyrolic sphincter. Now what do we call this pyrolic sphincter? We call them as anatomical sphincter. That means whenever you are seeing the organ, you can feel it. Whenever you can, just like seeing this particular organ through endoscope, we can see this particular sphincter as well. This is a highly condensed circular muscle of the stomach which is condensed around that part and becomes condensed and makes a sphincter. This is a circular sphincter. Just like a sphincter we have our anal canal, we call them as anal sphincter. That's a kind of sphincter we have in a urethra, we call them as urethral sphincter. So similar kind of sphincter which is feasible, demonstrable, and anatomically existing. So this kind of features this particular stomach which is existing into the parts of it which is existing on it. So moving from this particular stomach, from these parts, as I am saying, fundus above, we have this particular body, and lower limit is done by this particular angular notch. We have the sphincter existing on it, which is having this particular muscle forming around, and it is demonstratable. And I'll repeat it. This particular question we ask you in examination, despite asking easy question, we do not get the answer about this particular simple word. What do you mean by the physiological sphincter, and what do you mean by the anatomical sphincter? And we get a big zero on your face, which is really disappointing, and that just like freaks out during examination. That gives an impression we do not understand anything, and dumbest thing which is going to be during your anatomical viva examination. So please pay attention whenever you are reading, and if you are not liking to read it, do not read it. Do not pretend like you have to read it. Nobody is forcing it. But even if you are coming to the examination, just like come with the basic knowledge of understanding, what do you mean by the physiological sphincter and what do you mean by this anatomical? And without asking and saying that, you do not expect you to get promoted to the higher classes. Without answering it, you are not going to, no point, you are going to be passed to next classes. That's what it happens. Right? So, sphincters are two different, and these two sphincters involving it, we have diseases, because that's what you have to treat in your life. If you do not understand this, you cannot treat your patient. That makes you very unsuccessful as a physician or as a surgeon, whatever you are going to be. Anyways, coming from this particular ends of this particular fundus body and the pyrolus, we have an entity, we call them as gastric canal, which is more physiological than that of anatomical. Why we are saying physiological? Because I cannot demonstrate that particular gastric canal to you. So we have three kinds of muscle existing on the stomach: outer longitudinal, inner circular. There is a third kind of muscle exists on the stomach. We call them as oblique muscle. That particular oblique muscle of the stomach directed through this particular lesser curvature, directed obliquely like this. Now whenever we take the food material, consider that we take this particular fluid and we take this particular hard substance, that means bolus. So whenever you take this particular fluid, it needs a quick way to pass through, because it do not need to stay to the stomach for a great period of time. So it needs a quick bypass, just like we have this particular motorcycles runs in a faster lane than that of four-wheelers. So motorcycles have got like a two-wheeler things which runs in a faster queue. They runs through the small aisles. So similar to that, if you have the fluids that runs quickly through this particular stomach and goes to the intestine and passes out. So to pass this particular fluid material quickly through the stomach, we have a track. We have a fast track. That particular fast track is created by this particular contractions of the oblique muscle that creates a kind of canal-shaped structure. We call them as gastric canal. So this particular liquid material, fluid material, gets to this esophagus, to the stomach. Once it gets in the stomach, it quickly takes this particular route of the gastric canal, because this particular contractions of the oblique muscles is stimulated by this fluid material, and this particular gastric canal, through it, it passes out. Compared to the food material, if it is a bolus or solid one, the food material drops to this particular body and settles down to the bottom of the body, then it goes for the churning, and slowly it is getting out of this particular pyrolic sphincter as it is required. So there are the two basic mechanisms of passage of the food materials, liquid with the solid matter from the fruit. But anyways, so this particular gastric canal, which involves in the lesser curvature, which is a quick end route for the fluid material passing from the stomach. So this is important for the disease as well. Say for example, if the person swallows or tries to commit suicide, consuming some kind of corrosive substance, alkaline or acid, that burns this particular stomach, not the entire stomach is burned. It burns this particular curvature. It's a kind of defense thing also stomach that has. If you have something corrosive, fluid material gets into the lesser curvature, that saves the rest of the stomach. This part of the stomach is damaged. We repair this part of the stomach, and this particular patient's stomach utility is still there. But anyway, this is way beyond. It's way beyond. It's a kind of MCH topic that we just brought here. But anyways, coming from this particular region, about importance of this region, of this X-ray. Now, many a times we throw these particular X-rays to ask you about this particular sciagram, which is the anterior posterior diameter AP view, which we are seeing here, and point over here, this particular region. So this particular region is below the diaphragm, which is lying over here. This line is the diaphragm. This is this pulmonary shadows, and below here we still see some gases in here. And we ask about what this particular shadow is meant for. And again, 80% of the cases we do not get this particular answer correctly over here. This is the dome of the diaphragm, which is under to it we have this particular gas shadow that is created by this particular fundus of the fundus of the stomach, which is filled up only with gas shadows. So it's a simple answer, and then we can land up into the parts of the stomach that comes with this difficult question. If you answer that lands up into the easier form of answer. What are the parts of the stomach, etc., which you can easily answer. But unfortunately, we cannot answer this particular simple question, and next part we never achieve or never reach. That's why we end up in losing marks and failing to pass. Anyways, moving to this particular stomach, as I have mentioned, this particular stomach has got this particular stomach, which is present in the body, cadaver, dissected out, liver is sectioned out, and you see that how the stomach is there. This is the greater curvature facing this particular spleen side. This is the spleen, and this is the lesser curvature facing this particular stomach, facing this particular liver side. This is a lesser curvature, this is a greater curvature. This part we call them as fundus, body, pyrolus, antrum, and this canal, and then we have this duodenum. This is the region we find these positions of the pyrolic sphincter. This is the region we find this particular, the cardiac sphincter, which is physiological. So this is the entire rotations of the stomach, how we see that. Now coming to this particular attachments of the peritoneum. As I mentioned, this particular anatomy in this abdomen gets complex when you get into this peritoneum, because we do not understand this peritoneum cavity, we do not understand the peritoneum complexities which is having. Indeed, it is very complex. But anyways, just make it simple in a way. The peritoneum of this particular region of the stomach, which is modified, and this particular modifications of the peritoneum, we call them as omentum. What is this peritoneum? It's just like similar to the pleura, similar to the pericardium that we have in the thorax. This is the same thing. It is kind of like a covering. It also have the same layer, parietal and visceral layer. In between them we have the space. We call them as pericardial space in case of this particular liver, in case of this particular pericardial sac in this region. Here we call them as peritoneal space, which is lying in between this particular organs. But again, this particular stomach is fitted with this particular fold of this particular peritoneum. We call them as omentum. So there are two such omentum or peritoneum reflections are there. One is involving this greater curvature of the stomach. One is on the lesser curvature stomach. This particular region we call them as lesser peritoneum. What do you have to understand? The extent of the peritoneum. That means the lesser omentum is extending from what to what. So you see that this particular lesser omentum is extending from the lesser curvature going to this particular undersurface of the liver. So it is superiorly extended to this particular liver, and below it is anchored to this lesser curvature of the stomach. That the extensions of this particular lesser omentum that you have to keep in mind. What is peritoneum fold? Which is modified here, gets this particular name as omentum. We call them as lesser omentum. Now, this particular lesser omentum, which is present over here, on the reverse side, we have the greater omentum involving in this greater curvature, which is anchoring or helping down from this particular, covering this particular entire stomach and dropping down like this. And this particular omentum, which is on this greater curvature, is way big. We call them as greater omentum. It looks big and it is a size big, and as well as its functions big. We will talk about it. So this particular two omentums that we have to know. Now this particular omentum, let's take this particular omentum, we call this as the lesser omentum. So this lesser omentum can be divided into two parts. One is a part which is extending from, so it is part 1, so which is marked by part 1 like this. And the part which is coming from this particular liver and going to this particular duodenum, which is part 2. So this particular lesser omentum, it can be divided into two parts. We call them as gastrohepatic part and hepatoduodenal part. So these are the two subparts or subcomponents of this lesser omentum that you have to remember. Now, this omentum, which is lesser, one and two. So liver to stomach and liver to intestine or first part of duodenum. So this is what we have to keep in mind. This is the two parts of this particular 1 and 2 of this. Now what important over here, within this particular omentum, which we call them as lesser omentum, we have some contents fixed into it. What is lying in here is some blood vessels. So within this particular omentum, we have two arteries or two vessels lying. We call them as gastric vessels. We have two arteries or two vessels. We call them as left gastric artery, also known as right gastric artery. These are the two arteries. They are content of this particular lesser omentum. So in terms of this particular lesser omentum, we have this particular vessels lies as a content of it. That's what you have to keep in mind regard to this particular omentum. So we have to know what the omentum means, what is the lesser omentum is, how far it is extending, and what are the parts of it, liver to stomach and liver to this duodenum. And within this particular peritoneum, if you rip this, you see two blood vessels lying in it. We call them as gastric vessels. There are two vessels are there supplying here. We call them as right gastric artery and left gastric artery. Right gastric vein and left gastric vein. These are the components of this. You have to memorize this piece of information. Coming to this particular greater omentum. So just like the lesser omentum, this greater omentum also have few divisions or few subdivisions. If you look at this particular picture, you see that this is the greater curvature of the stomach, and from the greater curvature of the stomach, this is the omentum, it is hanging down. So this particular greater omentum has three parts. One is over here, 1, other is 2 and 3. So we call this upper part of this greater omentum from this curvature to this particular undersurface of the diaphragm. We call this part of the undersurface of the diaphragm to this particular stomach, we call them as gastrophrenic, phrenic by this particular diaphragm. So gastrophrenic part, a part of this greater omentum is extending from the stomach to the spleen. We call them as gastrophrenic part, and a part which is hanging down below this transverse colon, we call them as gastrocolic part. These three together, we call them as greater omentum. So these components of this greater omentum, if you have to keep in mind. So again, the extent of the greater omentum is from the greater curvature to this particular undersurface of the diaphragm to the spleen and to the colon and hanging down below. So this is how this particular greater omentum is hanging, just like an apron which you wear. So these particular components of this greater omentum, just like the lesser omentum, have got two components. We call them as liver to the stomach and liver to this particular lower part, which is called them as hepatoduodenal and hepatogastric part. It holds these two vessels. In here also, it holds two vessels. We call them as gastro-omental arteries or gastro-omental vessels. So in here, we see this particular omentum or this particular greater omentum holding some vessels. So here, we have some blood vessels involving the greater curvature. We call them as right and left gastro-omental artery, gastro-omental veins. They are content of this. We'll be coming to talk about the blood supply of it. Then this particular thing will be covered once again. So this is how this particular greater omentum and lesser omentum, that what you have to study. How far it is extending, what are the parts of it, and what are the content which lies in it. Now taking from here, we go into the major part of discussion, which is this is what we are talking about, the peritoneal attachments and this particular ligaments which is related to it. Now we go to this particular the blood supply of the stomach and this nerve supply and the lymphatic drainage of the stomach. So we land up into the blood supply of the stomach. So this is what you have to focus little bit regard to the blood supply of the stomach. So in stomach, we have this arterial supply coming from the branches of abdominal aorta. And the abdominal aorta has a branch, we call them a celiac trunk. So that particular celiac trunk have got 3 branches going in 3 different directions. So if you see this particular celiac trunk, just like a circular element. So it has a branch moving to the right side and the left side. Right side branch which is going from this celiac trunk, we call them as SA. Splenic artery which is moving up, we call them as LG, which is heading to this right side, we call them as hepatic artery, HA. So this is what we are seeing here is this celiac trunk. So there are 3 different directions of these arteries going on. This one which you see here, curvy, tortuous, is splenic artery, going to the spleen. This one which is heading up and curving back, we call them as left gastric artery, LGA. And other one which is heading to this particular opposite side, right side, we call them as hepatic artery. So 3 different directions, we get this particular 3 different branch of the artery of the celiac trunk. Unless until you memorize this, we cannot go in beyond, learn about the blood supply of it. So this particular celiac trunk, as I am saying, have got throwing 3 different branches, 3 different directions. Now we see that this branch, which is known as splenic artery, we take this at a time. So splenic artery, which is tortuous and easy to identify, goes to supply to the spleen. Story ends there. But this particular branch, which is splenic artery, apart from supplying this particular spleen, it also do supply with some other branches in different parts of the stomach. So you see that from the splenic artery, it sends a branch which moves up and goes to supply the fundus region of the stomach. So these branches which is moving up from this particular splenic artery, we call them as short gastric artery. It supplies the fundus of the stomach. So this particular short gastric artery which moving up from the splenic artery supplies to it. Another artery which we see that from the splenic artery drops down, grows to the greater curvature. So this branch which grows to the greater curvature runs into the omentum which is lying in here. What omentum lying here? We have the greater omentum. So this branch which is lying in here, we call them as left gastro-omental artery. It is coming from the left side because the spleen is lying on the left side. This branch we call them as left gastro-omental artery. We have to remember this. So left gastro-omental branch which is dropping on and covering this particular greater curvature of the stomach. Now, from this particular artery, splenic artery, these 2 branches we have to keep in mind, short gastric and this particular left gastro-omental. Now we go to this particular branch as left gastric artery, which is a direct branch. You see that this moves up and loops back like this. So this particular left gastric artery goes like this and gives some branches. These branches moving up to the esophagus. We call them as esophageal branch of left gastric artery. The main artery curves down and lies within this lesser curvature, within this particular lesser omentum. It is the content of this which we just mentioned above. So this particular left gastric artery supplies the lesser curvature of the stomach, accompanied by a branch which is coming from the hepatic artery. So hepatic artery sends a branch which drops down like this, coming to the right side. This is liver lying on the right side. So this branch which is going from the right side, we call them as right gastric artery. Right gastric artery eventually drops down to the bottom side of this lesser curvature and joins with the left gastric artery, makes an anastomosis and supplies over here. So this left gastric artery, right gastric artery, anastomotic branch supplies this particular lesser omentum. So this particular lesser omentum is supplied by this particular arterial anastomotic branches coming from the LGA and RGA. They are branches of celiac trunk in short. Now you see that this particular branch which is known as going down, we call them as gastroduodenal artery. In short, we call them as GDA. So this gastroduodenal artery is a branch of hepatic arteries. This is a hepatic artery, a branch which is dropping down, we call them a gastroduodenal artery. It's going to supply the stomach and the duodenum. That's why you get this name as gastroduodenal artery. So this gastroduodenal artery sends a branch which is going to meet this left gastromental artery, which is known as right gastromental artery. So this right gastromental arterial branch, which meets with the left gastromental arterial branch, makes an anastomosis, lies within this particular greater omentum. So that's why this lesser omentum and this greater omentum is a place where you see this anastomosis of two arteries, right RGA, LGA and omental artery, right and left. They are present on the greater curvature and lesser curvature, and by this they supply this entire region. So we have this stomach, we have this particular gastromental. We have this hepatic artery, we have this GDAs going down. GDA sends a branch over here, we call them as right gastromental. Like on this particular, it sends a branch which meets with this particular LGA, we call them as lying with the lesser curvature. Omental branches, they are lying on the greater curvature, supplying with it, along with this particular short gastric artery, which is coming also from the splenic artery, supplies this particular domains of the stomach. So this is in short about the blood supply of the stomach. So we have to learn about the celiac trunk. We have to know these particular branches of the celiac trunk, three basic branch, and how these three basic branches of the celiac trunk breaking down into smaller branches, and each of these branches, how they are contributing on the surface and the margins of the lesser and the greater and these different components of the stomach and supplying to it. As you have these particular arterial branches, we have the corresponding veins accompanying to it. That means if you have the LGA artery, that means we have a LGA vein. If you have an RGA vein as well as the artery which is lying on it. So that's why we call them as vessels. So this particular anastomosis taking place on this lesser omentum, anastomosis taking place in the greater omentum, they are your exam question. Anastomosis are the branches coming from this particular fundus of the stomach, blood supply to it, which is coming from the short gastric artery, that you have to know. And you have to memorize, remember, draw and see this particular thing really well to comprehend well, and so that you will be able to answer. So this is in short about this particular blood supply of the stomach. Now coming to this blood supply from it, let's talk about this particular lymph. The stomach is really complex. Let's draw it and memorize this particular simple form of it. So this particular, for example, this is a stomach. Pardon my poor drawing, horrible drawing rather. So this is a stomach that we have to feed it with. Now in terms of this particular lymphatic drainage, we call them as, there are two sets of lymphatic drainage that is important. One is the level 1, that means once this particular lymphatics is there, that is receiving from the organ itself, the direct entry. And level 2, that means once they reach to the level 1, then they move to the higher level 2 lymph nodes. So there are 3 level 1 lymph nodes, or 1, 2, 3, 4 level 1 lymph nodes. And that particular level 1 lymph nodes, all of them drain to this higher group of lymph nodes, which is known as level 2. There is one level 2 lymph nodes. So we divide this particular stomach into two parts, like upper 2/3 and lower 1/3. And again lower 1/3 we divide into right and left like this. So from this region, the lymphatic groove drains to these two groups of lymphatics. So these two groups of lymphatics, we call them as pancreatico-splenic lymphatic group. So PA's group, pancreas and the spleen, together we call them as pancreatico-splenic group. So these portions of this particular stomach drains into this group of lymphatics, pancreatico-splenic group, PS group. It largely drains over this region. Along with that, we have this particular section which is lower 1/3, which drains into two groups of lymph nodes. Right side, it drains to group of lymph nodes. We call them as pyrolytic group of lymph nodes. In short, we call them as PY, pyrolytic group of lymph nodes. And from the bottom side, or this particular left side, it drains down below. It drains to the group of lymph nodes which is lying below. We call them as pancreatico-intestinal group, like pancreas and intestine or duodenal, which is lying below. We call them as pancreatico-duodenal or intestinal group. So this is, in short, in an easier way of representing the lymphatic spread of this particular normal tier 1 lymphatic drainage of the stomach. So they drain to this particular 3 or 4 groups of lymphatics which is present in here. Upper 2/3, lower 1/3, right and left. Now from here, they drain to the level 2 lymphatics which is known as celiac group. So all of these, that means these 2 and 3, 1, 2, 3 drains to this particular second degree lymph node which is the celiac group, which is draining in. So if you have a cancer of the stomach that spreads predominantly through the lymphatic routes, if you have to remove this organ, you have to remove these lymphatic groups, which is not easy, rather most daunting task. We cannot remove them. Why it is required to remove? Because the cancer cell sits into the lymph groups. You remove this stomach which is cancerous, but leave this particular live cancer cells in these lymphatic groups, it's again going to recur. It's going to have cancer again in some other organs. We call this as a METS, which is going on and on. So that's why identifying these particular lymph nodes, which is tier 1, dissecting them out during surgery is important. That's why we ask this particular lymphatic drainage question. This is one of the important region where you see this stomach question is coming, blood supply, lymphatic drainage. Coming from this particular lymphatic drainage, we have an awful moving slide, I don't know why. Okay, finally. So we have this particular nerve supply. We supply with the sympathetic nerve and the parasympathetic nerve. That means it is either contracting or peristalticating this particular stomach. Either stomach is holding or it is pumping out of it. So this particular thing comes with this parasympathetic nerve which is coming from this cranial nerve, which is number 10, which is known as vagus. Vagus have got 2 divisions, anterior divisions and the posterior divisions, which is supplying to this particular region. And this particular sympathetic nerve which is coming from the sympathetic chain, going to supply this particular counteracting parasympathetic nerves, which is together supplying this nerve supply of this particular stomach. In detail, I maybe have to, it would be good if I have explained this with a lot of detail about the nerve supply, but in a true sense at the undergraduate level, we do not bother about this particular nerve supply because these 2 simple words, vagus and sympathetic, if you remember this, it's good for us and enough for us to pass the examinations. But you have to know the detail of this particular lymphatic and the blood supply because more and more exam questions are on it. So they prepare this particular thing which is known as the nerve supply. In short, like it is coming from the vagus, anterior and the posterior vagal nerve and sympathetic nerve which is supplying through this particular sympathetic chains, and the blood supply and the nerve supply, that means vessels and where this particular anastomosis is taking place, that is more important for us to remember. So this covers this particular entire stomach in terms of the gross. We have to know the parts of the stomach which is related to different components. We have to know this particular anatomy of this particular stomach in terms of knowing this relevance of this omentum which is anchored to it. What is the normal content of this particular omentum, less or greater, what blood vessels lies on it, what is the anastomotic part, what are the different parts of the stomach supplied with which different branches of the celiac trunk. They are coming with the pictures and the schematic drawing. You must prepare well. Let's move to this clinical part. We call them as gastroesophageal reflux disease. So coming back to the sphincter where we have started, we had 2 kinds of sphincters. One is anatomical sphincter, other is physiological sphincter. Let's talk about the physiological sphincter. Now, as I am saying, this physiological sphincter is lying on the cardiac end of this particular stomach. That means that part of the stomach is related to the heart. That's why you call them as cardiac end of the stomach. Now, this particular region, sphincter, which is either it's too tight or loose. Now, if it is too loose, that means it is making some kind of regurgitations of the food material if you have ingested. Say you have taken 2 liters of fluid, and that particular fluid, instead of going down to the duodenum, it is refluxing or moving up to this particular mouth. That thing we call them as reflux. That is reverse directions of the fluid which is happening. So normally we have a tone of this particular lower esophageal sphincter, also known as this cardiac sphincter. Now, if this particular tone of this sphincter is too less, that is leading to this particular emptiness of the fluid material into this particular esophagus. So, fluid material is refluxing back into the esophagus and creating a disease. We call them as gastroesophageal reflux disorder, GERD in short. It's a big name, right? So, by the time you mention the disease, the patient already have, that's why I call them as GERD, which is one of the commonest thing which you experience, which everybody experiences. So, it's a kind of reverse peristalsis which is happening to trigger over here before vomiting. The commonest clue the patient gives over here is that they give this, we get a bitter sensation whatever we take the food, or no matter we take the food, we get a bitter sensation. The bitter sensation is the key of the reflux thing. Whenever this particular thing is refluxing the acid rich material, it creates some sensation to this particular patient, gastroesophageal reflux disease. That means the tone of this particular sphincter is less. Now, contrary to this, if you have an excess tone, that means this particular sphincter is too tight. Then again we have a disease. What happens if you have too tight sphincter? The esophagus is presenting with the food which it cannot enter to this particular stomach. So basically, esophagus is a tube, has to dilate to accommodate the food material. If it is not delivering to this particular stomach, so then it makes this particular esophagus lower end dilated, and that dilated esophagus looks like a heart in an X-ray. We call them as achalasia cardia. You should write down these names, because once you tell your parents about these names, they will say, "Oh, you are doing good." That means, all right, I'll just like increase your incentive. Like, joto mashe taka patatam ekটু beshi patab, তুই ভালো করে পড়. So this achalasia cardia is like lower end of the esophagus becomes dilated because of the sphincter is too tight. That's another disease, right? So sphincter may be too loose or too tight, and each of the cases we get a disease. And if you get a disease, we earn money. So it's good to have the problems. Now, if you have too much of reflux, that creates this particular thing which is known as this particular carcinoma of the stomach. Now, interesting point about the carcinoma of the stomach. As I mentioned, this particular stomach cancer spreads through what? Lymphatics, 90% of 80 to 90% of the cases. That means if I have a stomach cancer, the lymph nodes will be draining through it, and it will be bypassing the cancer cell through the lymph nodes and moving on. Now, in case of the spread of the cancer, there is a remarkable or kind of surprising thing happens over here. Many a times the cancer do not present with this particular problem of the tummy. Rather, this particular cancer presents with a swelling on a nape of the neck. That means we have the clavicle. On the top of the clavicle, this region we call them a supraclavicular region. Make sense? So that particular supraclavicular region of the left side, we have lymph nodes there. We call them as supraclavicular lymph nodes. Now, in case of the cancer, if it is spreading through this particular group 1 lymphatic channels, then to group 2, and then it moves through further channels and reaches to this particular group of lymph nodes, which is known as left supraclavicular lymph nodes. So that particular left supraclavicular lymph nodes, if gets enlarged, we call them as Virchow's node by this discover. So this particular Virchow's, which is left supraclavicular lymph node enlargement, is a very, very threatening thing. because that means it has sprayed hell a lot of the cancer cells. That means that is a kind of, you can call it like near end stage of the cancer. So if you have a person who has no symptom whatsoever, only dyspepsia, acid problem, consistently saying, and you find this particular left supraclavicular lymph node enlarged, you should be super suspicious that it should be cancer. And this cancer may be coming from the stomach. You should be probing through. Right? So left supraclavicular lymph nodes, how this particular lymph node matters, we understand that. So moving from this other entity of this thing, we call them as other disease, we call them as ulcer. We call them as peptic ulcer, we call them as duodenal ulcer. Now we have this particular stomach. We have this stomach has got two curvatures, greater curvature, lesser curvature. Now you tell me, out of these two curvatures, which curvatures will be more prone to have ulcers? Lesser curvature. That's a normal thing that happens. Why? Because this is an easy track. Whatever the corrosive material it goes, whatever the liquid it goes to the lesser curvature. So acid content and high acid burden content is always draining that curvatures. And if you have this particular acid running in these regions, is naturally it's going to get some kind of breach on the mucosa. And that breach in the mucosa, we call them as ulcer. In case of the stomach, we call them as peptic ulcer. We call them a gastric ulcer. In case of this particular pyrolus, we call them as peptic ulcer. Now, why this particular ulcer is more common in this lesser curvature? We have another theorem. Apart from this particular lesser curvature, which is reaching more acid-rich content, there is other theory behind it. What is other theory to it? We have this particular lesser curvature is supplied with which blood vessels? Which arteries drains or supplies this lesser curvature of the stomach? Which arteries? Name the arteries. Gastric arteries. How many gastric arteries we have? 2 gastric arteries. What are the names? Right and left. Oh, very difficult question. Thank you. Now this right and left gastric arteries sends the branch which penetrates this lesser curvature and supplies it. The branch which penetrates it goes to the lesser curvature, are kind of very straight branch. What do you mean by the very straight branch? That means you cannot bend them. That means you cannot bend them. The blood flow runs to the straight artery is less. As a result of this, we have this particular region is less vascular compared to this greater curvature, which is supplied with this branch which is running along with the axis and sends the branch which is angular branch. That means it sends more blood flow to the greater curvature and less blood flow to the lesser curvature. As a result of this, the lesser curvature is less vascular, and that's why if it is breached, it takes longer time to recover. That's why the ulcer, if it is there, stays for a long time and remains there. This is one of these, another theorem which helps us to explain why this lesser curvature is more prone to have ulcer, and if the ulcer is there, why it remains for a prolonged period of time. This is one of the explain why kind of question. That's why you have to mention that what you have to explain, justify it. Now, coming to this, the pyrolus region. The pyrolus region also is having more exposure to the acids. Why? Because the pyrolus has a sphincter. What kind of sphincter it has? It has an anatomical sphincter. That anatomical sphincter is really strong. It's really strong. That means it checks rigorously before the food passes. You have to have a minimum criteria. So after that, only the food passes through it. As a result of that, the food material stays for a long period of time over this pyrolic region. And if the food material is high in acid content, stays for the longer period of time, the pyrolus is also exposed with the same acid content. That's why it is remaining for a longer period of time and eroding and burning that particular mucosa. That's why this pyrolus also is having a more prone to ulcer. That ulcer we call them as peptic ulcer. And this particular pyrolux region in next, like in pharmacology and microbiology, we are going to learn about, they are a resident of the bacteria, maybe living in there. We call them as H. pylori. So that particular H. pylori, we call them as Helicobacter pylori, that lives in there. That particular bacteria breaches this mucosa, digs in, and as a result of this, mucosa burns here. So result of this particular peptic ulcer more common in the first part of the duodenum and the pyrolus region is that prolonged stay, less vascular, and H. pylori, which may be causing this particular infections to leading to the pyroli gastric ulcer, etc., etc. This is a kind of explain why kind of question, that what you have to mention, that what you have to answer. Taking it from here, this is little bit higher grade, but I'm just like explaining it. Later on you can come over here. So if you have the ulcer on the lesser curvature, that means if this particular ulcer is eroded and it ruptures. So if it eroded, the acid content will be liberated out and eroding these blood vessels. Now if this particular blood vessels is eroding on the lesser curvature, which blood vessels is going to bleed? The gastric arteries. Similar to that, if you have an ulcer in the greater curvature, if it erodes, breaks down, which artery will be bleeding? Gastromental branches. These are the things we approach this. Similar to that, we have this particular artery lying behind this particular pyrolus region. We call them as GDA, gastroduodenal artery. So if you have the peptic ulcer posteriorly perforating, eroding this structure behind, that means gastroduodenal artery is going to bleed if you have this. So this is kind of like a little bit like an anatomical correlation that you have to make, that you have to do, little bit in a higher cognitive domain that you have to do. But anyways, I'm skipping it for now. I'm skipping this hypertrophic pyrolic stenosis because this is embryology, we'll talk about it. And anything else related to the clinical? Oh, this is about this particular endoscope. That's what we talk about. You put this particular endoscope through this particular region, and through this endoscopic approach, we can do the things. We can visualize this particular stomach, see this particular diseases, ulcer, etc., etc. Also, we can do surgery. We can do surgery to this particular pancreas. Where in a pancreas? In case of this particular pancreas, we may have a stone impacted. We just had the picture. We may have a stone impacted in here. We have this pancreatic stone, maybe here as well. So we can reach to this particular stomach, to this duodenum, and reach to this particular point, and through this particular endoscope, we can reach in here, do the surgery. This kind of surgery, we call them as endoscopic surgery. In short, we call them as ERCP. So this particular ERCP surgery or retrograde enterocholangiogram, through the endoscope we can do the surgery, and as well as we can visualize the thing reaching to this particular point. But again, just like let's stick to this particular ulcers and this particular reflexes regarding to this particular anatomy of this particular stomach. So we have to know about the stomach. The blood vessels and the lymphatic is the prime importance. Apart from that, we have this particular peritoneal attachments, which is known as mesentery, the content of the mesentery that you have to know, and the clinical explain why of these things about related to the diseases of the stomach that you have to know. So this is all about this particular stomach. Thank you.
Is ureter. So if you see what is the length of the ureter, could you tell? What is the length of the ureter? Any idea? 8, 2 to 3. কত হবে বল? It is about 10 inches or 25 centimeter. Okay. So here you could see the ureter having free constriction. Okay. Ureter are having free constriction. কোথায় কোথায়? Number 1. This thing we will see also in the gross anatomy. Number 1, you will get over here, that is known as renal pelvis, where it initiate, okay. Then second one, where it crosses the pelvis, okay. Second one, where it crosses the pelvis. And the third one is where it enters the urinary bladder. These are the three constriction. Why constrictions are important? Suppose any kind of renal calculus. Okay. So there obviously the stone would be having any kind of obstruction to this constriction. Just like we have found in the esophagus, right? Esophagus এর চারটে constriction আমরা পেয়েছি। কোথায় কোথায় বলতে পারবি? Number 1, where are the 4 constriction of esophagus? একটা হচ্ছে তোর where the trachea bifurcate. Okay, then second one, where the arch of aorta crosses. Then third one, where it passes through the diaphragm. Okay, and so actually total four constrictions are there. Okay, so same like the ureter also like the same. So as you could see, this is a muscular tube, right? So muscular tube, if you are doing cross section, what are the different layers you will get? So write it down, the three layers of ureter in histological cross section. In histological cross sections are from inside to outside. Okay, from inside to outside. Number 1, you will get the mucosa. Okay, then the second one is the muscular coat. Okay, and the third one most outside, that is known as adventitia. Okay, so what is the difference between this urinary system and GI tract? Urinary system আর কি পেয়েছিলাম? Mucosa, submucosa, muscularis externa, serosa. Okay, and serosa is a part of peritoneum. Okay, but here we are getting what? We are getting adventitia, just like the blood vessels, right? What are the 3 layers of blood vessels? Tunica, intima, IMA. Okay, tunica intima, tunica media, tunica adventitia. So here also ureter you are getting the same. Okay, just remember in between that there is a type of muscle. So which type of muscle you will get over here? Type of muscle? Smooth muscle. Okay, type of muscle is smooth muscle, but the layer would be different. Somewhere you will get circular, somewhere you will get longitudinal. Okay, so we will come across one by one. So number 1, what are the part you know already? I told, a pair of kidneys, a pair of ureter, then we are having the urinary bladder, and last one is the urethra. Okay, and the length of urethra is different. Okay, for female and male is different. Okay, that is also one thing of issue. That's why females are more prone for any kind of urinary tract infection. Okay, because urethra are much smaller. Okay, so that is another issue. So kidney are concerned. What are the different function you are having? Kidney are concerned the production of urine. Okay, you all know how the blood is filtered in the glomerulus, coming to Bowman capsule, then finally going where? To the proximal PCT, then loop of Henle, then DCT collecting tubules, and there you are having, it is entering to the renal pelvis, right? Major calyx, minor calyx. From minor calyx, where it is coming? It is collected to the ureter. Okay, je pyramid gulo thake minor calyx theke kothay asche? Ureter. Okay, so second, what is the main function of ureter then? It is just conveying the urine, okay, from the kidney to the urinary bladder. Then what is the main function of the urinary bladder? It is storing the urine for the particular time. So it is a temporary storehouse, okay, for the urine. Okay, sometime it is empty, sometime it is voided. Okay, whenever it is voided, the empty, otherwise it is extended or distended. What is the normal capacity of urinary bladder? Do you know? Bladder blast ho jabe. Any idea? ml 200 to 300 ml. Okay, 250, if it is crossing 250 or 500, then there would be urge of micturition. Okay, micturition means what? You won't say, as a medical student you have to say micturition. Okay, so just like parturition, okay, delivering a baby, defecation, passing of, so these are the medical terms. So micturition means urine, passing of urine. Okay, so during the micturition. So next one is, so one thing you have to know, as because presence of smooth muscle and in the ureter, what is happening? Same peristaltic movement is happening. Okay, যেমন peristalsis আমরা GIT তে পেয়েছি, same peristalsis occurring over here. Okay, so this thing you have to know. Ureter are the muscular. So this is the definition. Write it down. Definition of ureter is, ureters are the muscular tube that conduct the urine from renal pelvis to the urinary bladder. So it's a muscular tube. It's a muscular tube that conducts the urine from renal pelvis to the urinary bladder. Okay, by the peristaltic contraction of smooth muscle. এই যে conveying টা কি করে নিজে নিজে তো হবে না, so there is peristaltic movement of smooth muscle. Okay, that's why the urine is passing downwards. Okay, so this is the peristalsis of the ureter. Now see, this is the cross section. So rather than kidney, what are the other thing you could see? Which gland is superior to the kidney? That is the suprarenal gland or adrenal gland. And if you see the difference between two glands, one would be round shape, another would be trigonal shape. Okay, triangular shape. So both this kidney main getting supply from the which artery? That is the abdominal aorta. Abdominal aorta from that left and right renal artery. Okay, suprarenal gland has got different blood supply. Okay, what about the venous drainage? By the inferior vena cava. As you know, diaphragm, right? Diaphragm is a abdomen, it will enter. Okay, so it would be drained by the inferior vena cava. So if you see, just beside that you are getting the ureter. Okay, but you have to be very cautious in case of female, because ureter simultaneously we are also having uterine artery. ঠিক আছে, another structure pass করছে ঠিক ureter পাশে, that is known as uterine artery. ঠিক আছে, so that is very much important during any kind of surgery in case of female. Okay, so how it is entering to the trigone? Okay, so here next one is, what are the layer? Already I told you, from inside to outside. First one is the mucosa, then muscle coat, then adventitia. Now, so see, these are the constrictions. So just write it down, the three constriction. Number one is pelvico-uterine junction. Pelvico-uteric junction, number one. Second one is bifurcation of common iliac artery. যেটা আমি pelvis বলছি সেটা কোথায়? যেখানে common iliac, abdominal aorta টা এলো তো, now it will divide into common iliac. So where common iliac is again, you know, divided into internal iliac, external iliac. এই যে bifurcation টা হচ্ছে, this is the second constriction. Okay, for the ureter. And the third one is intramural part. So what is intramural part? Intramural part, where you will get, it is one of the part in the urinary bladder. ঠিক আছে, it is one of the part in the urinary bladder. So that is known as intramural part. So these are the three constriction. MCQ আসতে পারে, so you have to be very cautious. These are the three constriction. Okay, so whatever the stone used to obstruct, so basically this constriction you have to see. Okay, then see, this is the histological diagram. Okay, from inside, what is the basic feature you could see? See the lumen. How does the lumen look like? Write it down. It is a star shaped lumen. Okay, it has got star shaped lumen. আর এই ধরনের lumen আর কার কার আছে হিস্টোলজিতে পেয়েছি? Which are the other thing having this kind of lumen? Could you remember the appendix? Appendix. Okay, so there is how you will differentiate. There is a presence of lymphoid follicles. ঠিক আছে, আরেকটা কার পাবি? আরেকটা পাবি fallopian tube. Okay, these three look similar, but you have to identify with the distinct feature. এর কি distinct feature পেয়েছি? Star shaped lumen. Okay, and what is the epithelium you are getting? That is known as transitional epithelium. So now tell me, what do you mean by transitional epithelium? What are the layer you will get? How many layer do you know transitional epithelium has got? 4 to 6 layer. Okay, it has got 4 to 6 layer, okay, and the cells will look polygonal in shape, okay, with numerous nuclei, okay. So what will happening, it has got 4 to 6 type of cell, and most superficial layer is the flattened epithelium, okay, flattened squamous cell epithelium. So what is happening, this urine is very toxic, so it is hurting that particular epithelium, and it used to get shed. Then the next epithelium comes, okay. So layer by layer it is going on transition, so that's why it is known as transitional epithelium, okay. So this is the epithelium. So next layer you are getting what is it? It is the connective tissue, or you could also say this is the lamina propria, okay. And in the lamina propria, which thing you will get? You will get elastic fibers, right? Elastic fibers. This thing you have to remember. So write it down. Elastic fibers are embedded in the connective tissue layer of lamina propria. Okay. So this is the first layer. So mucosa consists of transitional epithelium, lamina propria with elastic fibers. Okay. Then the next layer you will get what? That is known as the muscle layer, muscle coat. Now see, muscle coat, what is the difference? আমরা কি GIT তে কি পেয়েছি? Inner circular, outer longitudinal. What is here? You are getting just opposite. Okay, you remember, just it is opposite. So inner you are having longitudinal, outer having circular. Okay, just opposite. So this is the muscle coat. And the last layer they have shown, that is, you could see these are the blood vessels. Okay, there is a presence of blood vessels, nerves, lymphatics. So that is nothing but the adventitia. Okay, so these are the different layers of the ureter. Okay, so now this thing already we have discussed. Okay, so this transitional epithelium in the mucosa, in that lies on the connective tissue which has got the elastic fibers. Okay, and this last line you write, the mucosa thrown into, how it will give the appearance of star shape. The mucosa thrown into different folds. Okay, the mucosa thrown into longitudinal folds which give star shaped appearance in cross section. The mucosa thrown into longitudinal folds which will give star shaped appearance in the cross section. Okay, so this is first one is the mucosa. Then see next one, muscle coat. So what is the difference? So see, it is consist of smooth muscle arranged in two layers. That we already know. That is inner longitudinal, outer circular. But what is happening? Upper, it is present on the upper 2/3. ঠিক আছে? Total ureter শুধু upper 2/3 this layer will present. Inner longitudinal, outer circular. আর lower এ কি হচ্ছে? In additional আরেকটা longitudinal coat ঠিক আছে? গোটা ureterটাকে যদি if you will divide upper 2/3 in the lower 1/3, তাই তো? তো upper 2/3 এ কি থাকবে? Inner longitudinal, outer circular. আর lower 1/3 এ কি থাকবে? Inner longitudinal, middle circular, outer longitudinal. Okay, it has got 3 layers. So this is the difference between the muscle coat. So where you are getting the cross section, that is important. You may get 3 layer or you may get 2 layer. Okay. So next one is the adventitia. So adventitia we already discussed. Okay. What is the main thing here you will get? That is loose connective tissue. So write it down. Adventitia consists of, it is the outermost coat. It is the outermost coat surrounding the muscular coat, outermost coat which surrounding the muscular coat, made of loose connective tissue, okay, containing the blood vessels, nerves and the lymphatics. Blood vessels, nerves and the lymphatics. These are the 3 things you will get. So that is the adventitia. So always remember, serosa and adventitia is not the same. Okay, serosa and adventitia is not the same. Why? Because serosa you will get mesothelium. Okay, serosa you will get mesothelium, but adventitia we are getting what? Loose connective tissue. Both are different. So these are the histological feature you have to write if you get the slide of ureter. These are the histological feature. Okay, number 1, there is a presence of transitional epithelium or urethelium. Then second one is star-shaped lumen. Okay, muscle coat made up of inner longitudinal outer circle. Unless or until you are getting the 3 layer, write down this 2 layer only. Okay, then the third one is outside, that is known as adventitia. Another point you could add. Okay, outermost layer is the adventitia. Okay, so you have to always keep the to the point thing. Okay, which you must write. Okay, if the ureter come in the slide, so you write these 3 points. Okay, now we will go to the slide. So see, this is the slide. Okay, this is the specimen we are having. So first one, what you are getting, transitional epithelium in the lumen, then the muscular layer, then last one is the adventitia. So you will get the dot shape red color thing, that is the blood vessels. Okay, by that way you could identify. Okay, now the urinary bladder. So what is the definition of urinary bladder? So write it down. It is a potential muscular pouch. It is a potential muscular pouch where the urine is temporarily stored and discharged out periodically by the urethra. During key process bolan, during micturition. So there is one thing, the both empty bladder and distended bladder located different anatomical position. Okay, if you are talking about empty bladder, how you will feel, and if you will have distended bladder, how it will appear. Okay, so both are different. So what will happening, empty bladder, it lies within the pelvic cavity. It is not coming to the abdomen. Understood? It would be below the pelvic cavity. It would be below. Where it is the position of the urinary bladder? That is below umbilicus. ঠিক আছে, তোকে যদি পেশেন্টে বলে the pain, suprapubic pain, এই পেনটাকে কি বলে? Suprapubic pain. So what do you mean by that? Below the umbilicus. Okay, below the umbilicus and the iliac crest. So that is the position of the urinary bladder. And when it is empty, it would be below the umbilicus. But when it would be filled like 500 ml, what will happen? It would be coming above to the abdomen. Okay, so it is found behind the symphysis pubis, number 1, and it resembles a 4-sided pyramid. This is very much important. It is tetragonal in shape. Okay, tetragonal in shape. It is looking like a 4-sided pyramid. Capacity already I have discussed, 200 to 300 ml. 200 to 300 ml. Up to 500 ml is normal. Okay, afterwards there would be urge of micturition. Okay, আর কখন তাহলে যদি কোনো blast করে, you should not go beyond that. Okay, so that is very much important. Mucosa. So what is the mucosa? First one is, it is lined by urethelium. Okay, and it is also lined by conducting passage of minor calyx to the upper part of urethra. ঠিক আছে, এটা কিন্তু ইম্পর্টেন্ট, কোথা থেকে কোথায়। ঠিক আছে, so it is the conducting passage between the minor calyx to the upper part of urethra. So what they are talking about? They are talking about urethelium. ঠিক আছে, so that is the extension of transitional epithelium. You write extension of transitional epithelium কোথা থেকে কোথায়? That is the minor calyx to the upper part of the urethra or the intramural part. Okay, minor calyx to the upper part of the urethra. So that is the extension of urothelium. তার আগে কি ধরনের মিউকোসা পাবি মাইনার ক্যালিক্সের আগে any idea so here we are concerned about the absorption and secretion তাই তো মেইনলি হচ্ছে খানিকটা অ্যাবজর্পশন হচ্ছে খানিকটা সিক্রেশন হচ্ছে কলুমিনার ওকে সিম্পল কলুমিনার এপিথেলিয়াম বোঝা গেল ওর উপরেরটা পুরো কিডনির যে লেয়ার গুলো so it may vary to PCT to DCT it may vary okay so mucosa of the empty bladder so why I have written like that both are different mucosa of empty bladder is different mucosa of the distended bladder is different okay so write down what is the appearance of mucosa of the empty bladder when there is no presence of urine right so what you will see it exhibit fold definitely it is empty so it exhibit fold থাকবে তার মধ্যে distended নয় so a fold থাকবে and it has got consisting about 5 to 6 layer 5 to 6 layer transitional epithelium টায় 5 to 6 layer থাকবে okay and the second one is there is a presence of surface cell okay these surface cells are very much important because they are acting as a osmotic barrier okay they are acting as a osmotic barrier osmotic barrier for whom for the urine okay so the plasma membrane thicken to form osmotic barrier so what about the distended bladder so it would be filled by the urine so whatever the fold it will disappear okay because it is filled with urine okay so it is actually looking like a balloon okay if you inflate it how will be and if you have the take it out the air how it will look it will the same mechanism okay so the epithelium becomes thin কতগুলো লেয়ার হয়ে যায় 6টা থেকে হয়ে যায় 4টে okay 3 to 4 layers only 3 to 4 layers কারণ দুটো লেয়ার অলরেডি শেড করে দেয় okay the superficial layer যেটা superficial layer most superficial layer it will become flat whenever there is a presence of urine the most superficial layer become flattened okay so that is the difference between the mucosa of the distended bladder and mucosa of the empty bladder now what are the special feature of the mucosa of bladder which are the distinct feature you will get okay so write it down the mucosa of the bladder suppose mucosa of stomach it is different mucosa of the urinary bladder it is different mucosa of the gallbladder it is different okay so what is the characteristic presence in the urinary bladder mucosa of bladder specially adapted to stretch okay because you don't know the volume of the urine okay so it permit great distension of bladder without damage to its surface integrity এটা ততটাই strong থাকে so that's why you are having these 6 layers okay so it is adaptive to any kind of stretch okay damage to its surface integrity so this is the main characteristic of mucosa of the urinary bladder okay so this is the special feature so muscle coat what is the difference in the muscle coat of the urinary bladder ureter e ki peyechi inner longitudinal outer circular here having inner longitudinal outer circular and then again the most outer there would be longitudinal okay so these are the 3 layer so inner longitudinal middle circular outer longitudinal okay so same like we have got the lower 1/3 of ureter same thing okay so that is the muscle coat of the urinary bladder now what about the adventitia so write it down adventitia there would be fibroelastic connective tissue okay in adventitia you are having এখানে ওখানে ইলাস্টিক ফাইবারস কোথায় পেয়েছি মিউকোসাতে ইউরেটারে কিন্তু এখানে কোথায় পেলাম একদম লাস্ট লেয়ারে adventitia okay fibroelastic connective tissue carrying blood vessels nerves and the lymphatics okay so could you tell me which are the two nerve that is acting on the bladder it has got two function একটা হচ্ছে emptying আর একটা হচ্ছে filling So which are the nerve plexus? Sympathetic, parasympathetic if you say. Okay, আমি কোথায় বলেছিলাম যে চারটে জায়গায় রিভার্স হয়, মানে প্যারাসিম্প্যাথেটিক কনস্ট্রিকশন করতে, সেই চারটে জায়গা কোনটা? সাপোজ ইফ ইউ আর হ্যাভিং কনস্ট্রিকশন অফ ব্লাডার, হোয়াট উইল হ্যাপেন? দিস ইজ নোন অ্যাজ, এটাকে কি বলছে? এমটিং অর ফিলিং? এমটিং। ওকে, সো এমটিং উড বি ডান বাই প্যারাসিম্প্যাথেটিক। ঠিক আছে, এমটিং উড বি ডান বাই প্যারাসিম্প্যাথেটিক। চারটে রিভার্স কোথায় কোথায় হয়? পিউপিল, সেকেন্ড হচ্ছে দ্য ব্রঙ্কাস, ব্রঙ্কোডাইলেটেশন, ব্রঙ্কোকনস্ট্রিকশন, এখানে রিভার্স হচ্ছে। আর কোথায় হচ্ছে? হার্ট রেট। And the fourth one is the urinary bladder. Understood? So these are the reverse. Constriction ke korbe? Parasympathetic. Dilatation ke korbe? Sympathetic. আর sympathetic এ কে আসবে? Sacral plexus. Sympathetic মানে কি? Cranio sacral না thoracodorsal কোনটা? চারটে প্যারাসিম্প্যাথেটিক নাম কি কি বল? ক্রেনিয়াল নার্ভ চারটে যেগুলো প্যারাসিম্প্যাথেটিক নার্ভ। Vegas, good. 3, 7, 9, 10. 3, 7, 9, 10. ঠিক আছে, তো এই চারটে হচ্ছে প্যারাসিম্প্যাথেটিক। তাহলে ক্রেনিওস্যাক্রাল হচ্ছে প্যারাসিম্প্যাথেটিক, আর একটা আমরা বলি থোরাকোডর্সাল। থোরাকোডর্সাল মানে হচ্ছে থোরাসিক প্লাস লাম্বার, ডর্সাল মানে লাম্বার, এটাকে এটা হচ্ছে সিম্প্যাথেটিক। বুঝতে পারলি? তাহলে নার্ভ অফ যেটা বলছে এমটিং, সেটা বাই দ্য প্যারাসিম্প্যাথেটিক ক্রেনিওস্যাক্রাল, আর নার্ভ অফ ফিলিংটা কে করবে? সিম্প্যাথেটিক। ঠিক আছে, so this is the difference. And superior, so see the last line, the superior surface of blood, already you have now known the peritoneum. Okay, so superior surface of the bladder is covered by peritoneum. এটা কিন্তু এমসিকিউ আসতে পারে। ঠিক আছে, কোন সারফেসটা কভার্ড থাকে? ওকে, okay, so see, so what are the histological feature you will get? Number 1, transitional epithelium. These are the histological feature if you see the slide of urinary bladder. Second one, thick muscle coat. There are 3 muscle coat. Most inner is the longitudinal, then circular, then the longitudinal. So what are the specific type of muscle you will get the urinary bladder? Write it down, detrusor. Detrusor. Detrusor is the specialized muscle found in the urinary bladder. Okay. And third one is that there is no presence of any kind of gland, because it has got no function rather than storage. Gallbladder also, only storage the bile. The same like storage house of the urine. It has got no function, kono gland thakbe na, kono mucus gland, nothing would be there. Okay. So this is the histological feature. So see, this is the bladder. How does it look like? So you could see এটাকে কি বলছি? মেসোথেলিয়াম। ওকে, এটা গ্রস অ্যানাটমিতে আরো ভালোভাবে পড়বো। এখানটাকে কি বলছে? which is attached to the umbilicus, that is সেটাকে কি বলছে? median umbilical ligament. Okay, and these are the junctions. So you could see it is a tetragonal shape, okay, or four-sided pyramid. So which one is the intramural? Where it crosses the ureter. ঠিক আছে, so you could see এটা কার ব্লাডার বলতো? ফিমেল ব্লাডার। why? because you are having this uterine artery. ওকে, আর এই জায়গাটাকে ব্লাডারের আরেকটা নাম হচ্ছে ভিসাইকা। ঠিক আছে, whenever you are having the name viscous, so that means the bladder. Okay, and what is trigone? See, this part is the trigone of bladder. এর মধ্যেও কিন্তু একটা ট্রাইগোন আছে, triangle, so that is known as trigone of the bladder. Why it is called trigone? because here is the urethra, আর এখানে এসে দেখ, see, this is the opening of the ureter. তো both side এ দুটো ureter, মাঝে urethra নিচে, so that's why it is creating the trigone. ঠিক আছে, তাহলে এটা হচ্ছে তোর bladder. Okay, so see, this is the four-sided pyramid, right? So it is distended bladder or empty bladder? It is distended bladder. Okay, distended bladder. So see, these are the layer. Okay, we are not having the slide, but you could see first layer, you could see epithelium ta kemon? Urothelium. Okay, which is underlying the lamina propria. Then next one is the submucosa, muscularis externa, the specific smooth muscle that is known as detrusor. ঠিক আছে, detrusor muscle টা কি হবে? Longitudinal, circular, longitudinal. So that is detrusor. Okay, and the last layer is the serosa. So that is found on the superior surface. Okay, so that is all about the histology of the ureter and urinary bladder. So now we are having the slide of ureter. You just go and see. Okay, what are the different features? Okay, thank you. So this type of thing also you could see. Okay, same, the epithelium, mucosa, smooth muscle and the muscle layer. Okay.